Are you ready for my next case?
Go for it.
Okay.
Ooh.
So this is a 24-year-old guy, and you can see he's got a lot of fatty angiomyolipomas in both kidneys. And then he had this big mass here. Actually, this is a good one for Matt. Not that I'm going to pimp you. But and then you can see that there's thrombus and enhancing thrombus going up the IVC, just stopping right below the or at the level of the hepatic insertion, not to the level of the hepatic vein insertion. So our thoughts were, is this an AML? But the only really fatty part of it was potentially along the edge here, like the bulk fat part. And we also had an MRI in this patient. I didn't upload it to my server, but there was no intravoxal fat in it. So is this an AML that has grown up here, but we don't see any fat in it, or is this an RCC? So one thing that I looked up was that patients with tuberous sclerosis get RCCs at the same rate, but they get them at a younger age. This guy was 24. And then the other thing that I looked up was that there's this entity called an epithelioid angiomyolipoma. Those can sometimes don't have as much fat, and they're on the malignant potential spectrum. So we raised that possibility here, and the reason it was important to raise that, I guess, is because they can be treated with mTOR inhibitors, some kind of new immunotherapy, and will shrink, and then maybe the surgery can be less extensive. This kid's dad was a neurologist. He just wanted it out, so they took it out. We didn't biopsy it. We didn't give mTOR inhibitors, and it turned out to be an epithelioid angiomyolipoma.
Is that different from the aggressive AML?
I think, so you can have an aggressive AML that invades, for example, it can be a typical AML and it can be invading into the IVC.
Right.
Just the component is actually different, and it stains for certain things like HMB 100 and SM 100. And so it's like a different kind of AML, and it has more of a malignant potential. I think it is different than an aggressive. Do you know, Matt?
I think the term aggressive AML is a colloquialism, but I think when we talk about aggressive AMLs, we do think, for me, that's what, when someone says that, that's what I hear is epithelioid AML. We did a little series on these, and basically you can't distinguish them from either side of the pole. So you can't distinguish them from regular AMLs, and you also can't distinguish them from RCCs when they look like this. So they're kind of a challenge. Like you said, they locally recur, and actually sometimes they can metastasize. You can actually have metastatic epithelioid AML. I think one I saw in the literature was a supraclavicular metastatic lymph node positive epithelioid AML. So
cool. Yeah. So I guess if we're in this situation, you could always raise the biopsy potential.
Do you guys do much biopsy of renal masses?
We're doing more and more. So some of them are for this possibility of is it, would it change? In this case, it could have changed management, and that they could have given that mTOR thing. If we've raised lipid poor AML on an MR, or if they're doing active surveillance of a small renal mass, we're doing more of those so that they can get more information to kind of counsel the patient on whether or not they should just do active surveillance or intervene. And then actually some of these really large ones, we're doing them for the clinical trials, for, I don't know, DNA mapping or something.
Yeah, we're doing a ton of them also for the same reasons you just described. I think we might do them maybe a little bit too much, but we do a bunch of them actually.
Yeah. One thing I also recently learned is sometimes, there'll be a bone met, and I'll be like, oh, we should go for the bone met rather than the actual RCC or the renal mass. But our MSK guys really don't like to, because these RCCs can bleed a lot. So if they're at all breaking through the cortex, like the posterior vertebral body cortex, and they could bleed into the spinal canal, they really don't want to biopsy those because of potential for cord compromise.
Interesting.
So then they let us biopsy them. We've had a couple of big bleeds, actually. So now
Masses, are you using any procoagulants or collagen plugs or patient's platelets or anything like that to plug up the hole you just made?
No, I mean, we often use gel foam, but that's it. I've never heard of using the patient's platelets. That's interesting. I know about blood patches for like lung biopsies, but I thought that was just blood.
Yeah, I think it's just blood. Basically, you just suck the clot out essentially, and then put it back in. We're using something called Helatine, which is like I think it's a collagen derivative. But for basically all kidney biopsies, after we're done, we basically embolize the tract for all of them.
With collagen.
It's called Helatine. I think it's a collagen thing. Let me check real quick and make sure that that's true. Yeah, it's absorbable collagen. It works really well, actually, because it clots, like even when it's pumping blood out, it clots it real fast.
Cool.